Dr. Yaso Emmanuel is a consultant cardiologist at Guy's and St Thomas's NHS Foundation Trust, and she has a specialist niche in Marfan syndrome. Dr. Emmanuel is here today to discuss specifically reproductive options and pregnancy with Marfan syndrome. Welcome, Dr. Emmanuel.
So I thought I'd just cover some questions that come up about really children for patients with Marfan syndrome and Loeys-Dietz syndrome. So the two things that I wanted to kind of go over, two aspects, would be, first of all, what's the worry if you have Marfan syndrome? Why do we worry? Why do you ask yourself, can I have children? What are the things that are going through your mind? And so the two kind of broad areas of things to think about are, one, the question is, will I pass the condition on to my children? And that's something that applies to both men and women with Marfan syndrome and Loeys-Dietz syndrome. So the question is, will you pass the condition on? And the second group of things I wanted to talk about was for patients who may want to become pregnant. Is it safe for you to become pregnant? So I'll cover those two aspects really today. So first of all, will you pass the condition on? So we know that there's, we do a lot of genetic testing, and we know that there's a genetic basis. So if there's a genetic basis for a condition, then yes, there is a chance that you could pass the condition on to your children. How high is the risk? And it may be up to 50%. So it depends on whether you have a change in the gene that is what we call a dominant gene, where if you have it on one gene, then if you pass that gene on, it's likely to be present in your children. So that's a 1 in 2 chance. So in all of us, we have 2 copies of each gene, one from your father and one from your mother. And if you have certain conditions where there's a change in one of those genes that causes a disease, and then you pass that faulty gene on rather than the non-faulty gene on, then it's up to a 50% chance. It's not always 50% because we don't fully understand the genetics that cause conditions like Marfan syndrome and Loeys-Dietz syndrome. So not everybody who has the condition are we able to identify a genetic change. So when we don't know what the genetic change is, we don't know what the chances are of you passing the gene change on because we don't fully understand. So there are some people out there who know that even though we make a clinical diagnosis of Marfan syndrome, sometimes genetic testing doesn't always give us an answer as to what the precise genetic cause is. Doesn't mean to say that you perhaps don't have Marfan syndrome or Loeys-Dietz. It's just that we haven't identified the genetic change. So when we do identify genetic change, we can sometimes say there's up to a 50%. When we're not able to identify the genetic change, but we know you have the condition, it's difficult for us to say what exactly the risk is of you passing the condition on, other than to say there possibly is a chance that it may be passed on. And then if could you pass the condition on? Does it matter? And I think the reason I put that statement in there is because it's a very personal thing as to how you feel about the conditions. Many people with Marfan syndrome or Loeys-Dietz syndrome may not want to pass the condition on. There are some people who feel it's not actually been so bad for me, it's not such a big deal. So it's a very personal thing as to whether or not, as to how affected you feel you have been by your condition and how important the risk of passing it on is to your child. Because everybody feels differently, and whatever you feel is fine. But it's just something that we just want to raise, that it's a very personal choice as to how important the reproductive choices are to you. We're here to support whatever people want. So if we do know what the genetic change is, what are the options? So certainly, even though I'm going to talk about things that we can do to prevent passing the condition on, that doesn't mean to say by any means that you have to follow any of these choices. It's perfectly normal and perfectly acceptable for people to just go ahead and have a natural pregnancy, in terms of a natural pregnancy, and not make any genetic diagnosis and just let nature take its course and see what happens. That's a choice that some people make, which is perfectly fine in terms of passing it on. Pregnancy itself, I'll talk about separately. So you don't have to take any of these choices if you don't want to. But if we do know a genetic diagnosis, and we do know that there's a confirmed gene in you that we know is the one that's caused the problems, then there is the possibility of pre-implant genetic diagnosis. And this is a technique whereby when we know what the faulty gene is, we can use a kind of IVF type process to select embryos that have not got the faulty gene, and then reimplant those embryos for pregnancy. The other thing that we can do is prenatal testing. So I'll come on to talk about that. And the other thing is adoption. And that's a choice that some people may want to consider because the other techniques are invasive. And so it's not for everybody, but having your own baby is not the only way to become a parent and have children. So it's a very personal decision, but it's a choice that some people may want to explore. So what does genetic testing offer? So like I've been saying, it's if we're able to identify the genetic cause in you, then it opens up some of these options for either pre-implant genetic diagnosis or testing. But if we can't identify a genetic cause, and there are many of you out there who may identify with this, we don't, even though we do genetic testing, and we know that there's a clear clinical diagnosis, genetic testing doesn't always give us a clear genetic answer as to what the cause is. Doesn't mean to say that if we've made a clinical diagnosis of Marfan syndrome or Loeys-Dietz syndrome, that you don't have the condition. It just means that the genetic changes that cause the condition are ones that the current testing that we're able to do hasn't been able to identify. If we do genetic testing, many of you will know it's not a quick process. It takes several months sometimes, and even years sometimes, to get a clear genetic answer. So it's something that we think about early on, so that we've got the genetic information to know what our options are, because it can take quite a long time sometimes. And even though we might talk about what genetic testing might offer for Marfan syndrome and Loeys-Dietz, and we can talk about potential options so that you don't pass this condition on, we only test for this condition. So we wouldn't be able to guarantee with any of these processes that your baby may not have any other genetic conditions, because we don't test for any of the other genetic conditions if there's no known reason why we would do. So you could still, the baby may still have a sporadic gene change that gives them another genetic condition. So it doesn't guarantee that you will have a healthy baby. It just means that if we are able to identify Marfan syndrome and the genetic cause in you, we could then potentially provide options so that you wouldn't pass Marfan syndrome onto the baby, but not other conditions. So like I just briefly mentioned before, pre-implant genetic diagnosis is a reproductive approach where we use in vitro fertilization, and we select embryos where we know that they do not have the culprit gene, and those are the ones that are selected for reimplantation. So because it's an IVF-based process, it can take a while, sometimes years. So it's a route that we talk about, then you need to prepare yourself for perhaps a long journey, sometimes years. It may not always be successful in the first cycle, but there's counselling that we go through and talk to you about the whole journey and what it might entail. And it's something that we would want to talk to you and your partner about, so that you know what you would want to take on and can make your assessment as to whether that's something that's right for you or not. Prenatal testing is not something that we do as much, but this is whereby some people may feel that pre-implant genetic diagnosis and manipulation of embryos is not something that they feel comfortable with, and they would much rather let nature take its course, but want to know whether the baby has Marfan syndrome or not. And so therefore, prenatal testing may be something that some people wish to have. And this is where where during the early stages of pregnancy, we can do two methods of sampling to see whether the baby has inherited the mutation. So we can either do chorionic villus sampling, where we take a small sample of placental blood, and we can do genetic testing. This can be done at around 10 to 14 weeks of pregnancy. And the other technique is amniocentesis, where we take a small sample of the fluid around the womb, and then that's got some of the baby cells in it, and we can look at those cells and identify whether those cells carry the gene change as well, and therefore whether the baby carries the gene change as well. And this is something that we can do at between 15 to 20 weeks. We don't tend to do it after that because there's not as much fluid around the womb, and so it's not quite as safe to take the sample at that point. So that's prenatal testing, and it's a thing that some people feel is appropriate for them when they just want to know. In that situation where you already have a baby that's viable and we make a diagnosis, it would be purely for making a diagnosis, but it's not a condition whereby we would offer any sort of termination of the pregnancy on the basis of this genetic diagnosis. So this is something that we would counsel you in detail about on an individual basis if this is something you wanted to think about, and talk to you about the potential outcomes before you make a decision as to whether this is something that you would want to pursue. I haven't put in slide in adoption, but like I said earlier, adoption is something that actually may be appropriate for some people, and it's something that you can think about, and it's a very personal choice. So with regard to pregnancy, what are the risks with pregnancy? What are the things that we think about with Marfan syndrome and Loeys-Dietz syndrome and pregnancy? And broadly speaking, we have to divide it into the risks that we think about for the mother, and then the risks that we think about for the baby. So what are the risks for the mother? So the risk for the mother of pregnancy is the extra workload on the heart and the blood vessels. So we know that carrying a baby brings on many major changes for the mother. So the circulating volume, the amount of blood within your system, increases by about double fairly early on in pregnancy. So within the first 2 to 3 months of pregnancy, the circulating volume within the heart and blood vessels about doubles, which causes a significant increase in the workload on the heart. And there's also various hormonal changes that happen during pregnancy that kind of soften the tissues up, partly to help with the delivery later on towards the end of pregnancy. So we know that the hormonal changes make the tissues a little bit kind of softer, and there's more blood circulating around, which places a strain on the system. And this can mean that what we worry about is whether the aorta, which is the big blood vessel that comes away from the heart and the one that we worry about with Marfan syndrome, that may be slightly more likely to enlarge with that extra workload and the hormonal changes. So that's something that we do monitor very closely in pregnancy, is the size of the aorta. And that's why if you do become pregnant with Marfan syndrome, you'll have regular scans to monitor the size of your aorta. And if it enlarges quite significantly or rapidly, we may need to think about urgent surgical treatment. So that's why we keep a very close eye on it, and we'll talk about medication to prevent that from happening. Aortic dissection, which is a tear of the blood vessels, is the thing that we worry about the most. And because of that increased workload on the heart and the blood vessels, the hormonal changes, the risk of a tear in the blood vessels is higher during the pregnancy, and that's why we keep a much closer eye on people during this time and in the early period after a delivery. So these are the biggest risks that we worry about for the mother. And what about the risks for the baby? So the risks come from some of the medications that you have to take, and that's why we review each medication with you and talk to you if you're thinking about pregnancy, and sees many drugs are safe, but some drugs we might need to change because they are not good for the baby and they may cause harm. And there are some drugs that we may need to change, some drugs that we may need to do some monitoring of the baby's growth. So we'll review all your drugs and talk to you in detail about the drugs that you would be taking or what you might need to think about if you were thinking about a pregnancy. Because we often advise medications to prevent the aorta from growing, some of those medications can sometimes restrict the baby's growth, and so therefore we often do monitor the baby for growth. But beta blockers are the main class of drugs that we use in pregnancy. But because they can restrict the growth, there is a small chance that your baby might be a little bit smaller than normal. And also, if we do end up having to deliver you slightly early, then the baby may be a little bit small. So the baby may be born a little bit early if we're worried about your aorta growing. And then, as I was talking about earlier on, the risk for the baby is also the risk of inheriting the condition. So if you're thinking about a pregnancy, first thing you should do is talk to your cardiologist to get an assessment of what your heart is like and what the risks of pregnancy are for you individually. And that'll be different for everybody. And one of the things that we'll need to do is make sure you've had some updated scans to assess your aorta. So if you're under regular follow-up but haven't been seen for a while, or if you've moved around and for various reasons, I mean, life sometimes gets busy, and if you haven't had a scan of your aorta for a while and you're thinking about pregnancy, make sure you get back in touch, and you need to get follow-up, and you need to have a scan to assess your aorta to see what's happening if you're thinking about pregnancy. Whilst talking to a cardiologist is important, your cardiologist doesn't work alone when we're looking after people during pregnancy. We work very closely with the obstetric teams and the genetics teams. And we offer you specific sessions to talk about the detailed risks of pregnancy. And that's a session that's usually done jointly between the cardiology and the obstetric teams. It's what we call specialist pre-pregnancy counselling. And we would talk to you about monitoring and what we would need to do and think about before pregnancy, what we would do during pregnancy, and also what the course might be later on in the pregnancy and delivery. So these are the kind of things that we would go through in pre-pregnancy counselling, and every woman has a right to have this individually, so you should ask for this and we should be able to facilitate that for you. So if your aorta is big, can you get pregnant? And this is something that you need to discuss in detail with your cardiologist as to whether or not we need to think about doing anything to prevent a problem during pregnancy, and sometimes whether we need to think about doing an operation to prevent further growth of the blood vessels during pregnancy. So that's something that your cardiologist and you will need to discuss in more detail when you're thinking about pregnancy. The key is to make sure you've talked about it and seen your cardiologist to get an assessment as to whether pregnancy is going to be safe for you. In general, if the aorta is mildly dilated but less than 4.5 centimeters and has been stable, then you don't necessarily need an operation before you can embark on a pregnancy. But it's like I say, it's important that you discuss this individually with your cardiologist. Surgery is not without its risks, so we don't necessarily jump to doing an operation just because you want to have a pregnancy. But it's important that you have the right assessment and discussion. If we do advise that you should have an operation before you're considering pregnancy, then make sure you don't get pregnant. So contraception is really important. Don't forget that bit. So just going to go in a little bit more detail. When you do come to the pre-pregnancy counselling, we go through your medical history in detail, not just the Marfans, but all the other problems that you may have had with your health and what impact they may have on a pregnancy. So for example, things like diabetes, various other conditions. So we'll make an individualised assessment as to your risk. We'll also assess your blood pressure, and we'll review all of the medication that you're on to see whether any of those are potentially harmful for your baby, and whether any of those need to be changed to alternatives that are more suitable for use during pregnancy. So we go through everything, things like anti-epileptic drugs, and so people are on all sorts of different things. So we go through everything at the pre-pregnancy counselling assessments. It's not just Marfan syndrome, it's a comprehensive assessment. We'll also talk about what your risks are and what monitoring we would need to do through the pregnancy of both you, your aorta, your blood pressure, and your baby's growth. We'll also decide, depending on where you live and how far it is from the specialist centre, where it's most appropriate for those assessments to take place, whether you need to come to a specialist centre for all of the monitoring during a pregnancy, whether some of that could be done closer to home if you live further away. These are all the things that we discuss, and what's the best monitoring strategy for you. Is there going to be a shared care arrangement with a specialist centre? So these are the things we go through. And then we'll also briefly discuss a pre-pregnancy, but more during the latter stages of pregnancy. We'll have some discussions around how you might deliver your baby, whether it would be a normal delivery, whether it would need to be a caesarean section. We think about the heart and the blood vessels, but we know that Marfan syndrome can affect the rest of your body as well, particularly the pelvis. And so we would look at all of that aspects in terms of how carrying a pregnancy would be for you and what the impacts that may have on delivery. So as part of the delivery planning, we'll also talk about where it would be. Do you need to be delivered in a specialist centre? Could you be delivered at your local hospital? We'll also make sure you've got a care plan for that. when you should deliver the baby. Do you need to be delivered early? Can you go to full term? If you're going beyond your dates, whether we would need to induce the delivery. These are all the things that we would talk about during the follow-up and the assessments. And we'd also talk about, we also have anaesthetists at some of those appointments as well to see, given your individual anatomy, looking at your hips and your spine, whether you could have an epidural or a spinal. So these are all things that we cover during those appointments. Many women who have Marfan syndrome can have a normal pregnancy with just monitoring and a normal vaginal delivery. So don't assume that because you have Marfan syndrome, you have to have an operation. We'll make all of those individual assessments, and many people do have normal deliveries. So just work with your team to make sure that you get the right advice. And then after the baby is born, what are the things that we look at? Well, we look at the medication that you need, whether any of that needs to be changed again. The effect of any medication that you might have on breastfeeding, that's also something that we would go through. And if the baby needs any monitoring for that, we'll also make plans for what follow-up assessments you need of your blood vessels and your aorta and your heart. And also we can talk about whether we need to do genetic testing on your baby if that's not something that has been addressed earlier on. Maybe if you've chosen to just let nature take its course, or you got pregnant without necessarily knowing. So we can talk about whether genetic testing needs to be done on the baby as well. So that's us rattle through. Hopefully that's been a helpful overview, but I'm happy to take any questions.
That's superb. Thank you so much. I'm just examining the questions. One lady actually wrote to me in anticipation of your talk. Unfortunately, she can't join us, but she's worried about successive pregnancies. She's had 3 babies. She has Marfan syndrome, needless to say. She's taking medication, and she wonders whether the body kind of replenishes itself after the first pregnancy, and so the second pregnancy is just like starting all over again, or whether there's an accumulative risk.
It very much depends. It very much depends on what your aorta is like, and whether your aorta was already a little bit dilated, and then with the strain of pregnancy, if it may have dilated a little bit more, then you went. So it's best that she gets an individualized assessment from her own team as to how her body and how her aorta has coped with the previous workload, and also it depends on whether there were any other complications, and also as you get older, the pregnancy, it does have different risks in, as you get older, things like high blood pressure, preeclampsia, all those things are also things that they review. So she probably would be best to get an individualized assessment as to what her pregnancy risk is. It's very funny. We all think we're young, but in obstetric terms, 35-year-old women are thought of as geriatric. So our perception of what's young and old is very different. So, if she's had 3 pre-pregnancies before, then obviously she's not as young as she was during the first pregnancy. What that means for the obstetric risks is something that it's probably better that her team talks to her individually about. It's not just the aorta, even though we focus on the aorta. Pregnancy means that you do need to think about the whole body and the risks of everything.
That's helpful to know. I think she's actually approaching 35, so that's
yeah. Yeah, it's quite a shock to the system sometimes when we talk to obstetricians as to what they think is old, which is very different to what we think of as old.
Definitely.
In normal everyday.
Geriatric doesn't sound that flattering.
It doesn't. Is it? Like I say, sometimes it feels very unflattering, and we all kind of walk in there feeling slightly uncomfortable because they're used to. But I think it used to be like that, but I think they're changing now because many women who are having pregnancies, the way that life is changing for many of us, we are getting older before we have pregnancies. So I think they're probably not quite as much like that as they may have done in the past. But it's more just because of the things that they have to think about with the biological age. In terms of risks of pregnancy. So it's things like preeclampsia, diabetes, all sorts of other non-cardiac things, as well as the cardiac aspect. So that's why it's important to get a comprehensive individualized assessment for everybody as to what your risk is.
Exactly. And Jose has his hand up.
I Thank you. Sorry, thank you for the talk as well. I was going to say that, do you have any genetic data to compare pregnancy that delivered normal and abnormal? And perhaps there is a pathogenic variant prediction to predict the outcome of the pregnancy, or this is just random?
It's very difficult because there are so many different factors that can affect the outcome and the delivery. Sometimes it's the individual anatomy. Sometimes there are obstetric reasons why you might have to have a cesarean section. Say the placenta might be lying in a particular position. The baby might be breech. So it may be that you have to have, the baby might get stuck. These are all things that are standard obstetric issues, nothing to do with the Marfan. So it's not something that we can make use a risk model to predict from a cardiac perspective. It's there are multiple different reasons, and so what we usually say is we can, speaking as a cardiologist, we can look at certain dimensions of the aorta, and we can say from a cardiac perspective whether we think it's likely or not you may need a cesarean section, but it entirely depends also on, like I say, obstetric factors such as the shoulder of the baby might be lying in the wrong position. There may be breech. There may be other things affecting the pregnancy. Also, sometimes it's practical things like, you live if the aorta's dilated, it's rapidly dilated. We may want to do something, but you may live far away. There are various individual factors that need to be taken into consideration. So it's an individualized assessment rather than a kind of risk model predictor that you can use to identify. There are certain things that we know may be more likely, and so we would talk to you individually about that.
Fantastic. Thank you.
And Terry's written, to say more recently, I had a chat with my son's genetic counsellor who mentioned a procedure to test the pregnant lady's blood. Can you give me more information, please?
A procedure to test the pregnant lady's blood. Is what more information is they given? So the genetic counsellor says.
Yeah, I had a chat with my son's genetic counsellor who mentioned a procedure to test a pregnant lady's blood. Can you give me more information? I don't know if Terry's elaborate.
Yeah, so I'm trying to work out. So if you during pregnancy, we can, it may be that, we meet people at varying stages, and sometimes, the question of Marfan syndrome might come up only when somebody becomes pregnant and somebody looks at them, and we may talk about genetic testing and take a blood sample for genetic testing during pregnancy, simply because that may be the first time we've met somebody. Genetic testing may take a while, so even though we take a blood sample during pregnancy, it might be after the pregnancy before we get a result. So it's difficult to know quite what they were meaning without a little bit more information. I mean, there may be other things that they were testing for, but if it was genetic testing to make a genetic diagnosis, usually we try and work out most of this information beforehand so we know what options are and we can give you more individualized information. So if they were taking a sample during pregnancy, I'm just guessing whether that was because it may be that that's the first time, sometimes people have, people move abroad internationally, and, so sometimes we only meet people for the very first time when we're contacted to say somebody's pregnant and there may be Marfan syndrome, or they're pregnant, but they've now got a family history of somebody being diagnosed with Marfan syndrome, or a blood test has come through in other family members. So say, for example, a family member has an event and Marfan syndrome is diagnosed, and they've had genetic testing, and it's taken 6 months or a year for a diagnosis to come through, and the diagnosis in the family member has finally come through, but you're now pregnant, and then we can sometimes do a blood test to see whether you've got the same gene as what's been identified in the other family member. So it's difficult to know precisely what they were meaning.
Sorry, am I able to talk? Can you hear me?
Yes. So was a question from you?
It was me. Yes, I'm sorry.
That's fine.
Obviously, I spoke to Victoria before. I've got a 20-year-old son with Loeys-Dietz.
Yeah.
And it was obviously mentioned quite a while ago when he was 18 about some of the things that will be offered. So as a parent, and Jake now obviously is not ready for a child, but he's obviously a little bit more aware of things. So I had a chat with his genetic counsellor after going to London, and she just explained the same as you, the different procedures and the different options. But then she mentioned that there is a new procedure where they can test the pregnant lady's blood to see if there's, but she did say, and this is what I was a bit vague about, it's not accurate at the moment and it's a new procedure, but they're hoping maybe in 10 years time when Jake's ready that it will have progressed. So I didn't quite understand what she was trying to
so testing somebody when they're actually pregnant then.
So it's the unaffected lady that is pregnant with an affected male.
Right. Okay. And this is presuming you've got a pregnancy whereby it's a natural pregnancy rather than a pregnancy with pre-implant genetic diagnosis where you just let nature take its course. And then at the moment, it would be if you wanted to know, it would be one of those prenatal testing options, so either chorionic villus sampling or amniocentesis. A blood test is probably still not quite ready for rollout in use yet, so I think it's
she did say that. She did say it's not accurate
and how accurate it might be is going to be difficult, because obviously if you want a genetic diagnosis in the baby, what we're trying to do is get some cells from the baby itself, because the baby's cells are what's going to give you the answer rather than the mother cells. So if you're taking blood tests from the mother, what you're testing is the mother's blood cells, which are not the baby's blood cells.
Right.
So it may not necessarily be as likely to give you a clear-cut diagnosis, because if you want to know what the baby's genetic makeup is, with regard to any changes from Marfan's or Loeys-Dietz, you would have to get some sort of cells from the baby, which is what the chorionic villus sampling and the amniocentesis do, is trying to get some cells from the baby itself to work out what their genes are, not the mother's genes.
Yeah, that's fine. Thank you.
No problem.
Just looking to see if further questions are emerging. I don't think so, but if anything occurs to anyone later whilst you're digesting this fantastic talk, then do email us. So thank you so much, Dr. Emmanuel.
No problem.
Thank you. Are you returning to work? Are you on call?
I'm catching up on the backlog and I've got a couple of people to see still on the ward. So yeah, but I'll be around.
Thank you so much.
Can I just ask you a quick question? What proportion of families actually go for the pre-genetic implantation?
Pre-implant genetic diagnosis?
Yeah. Because I kind of feel that all the people that I meet haven't, but obviously that's, I just don't know whether, is it many people taking it up?
Well, it's changing. And I think that part of that is because, we're now getting more and more people who are coming through where we've got a genetic diagnosis. So it's only an option, it's only possible for people in whom we've got a confirmed genetic causative change. And unfortunately, that's not everybody. So for quite a lot of people, unfortunately, it isn't an option, simply because if we can't identify the gene change, then it's not an option. But for the people in whom we do have a genetic change, it's an option, but it's not always that everybody feels it's appropriate for them. Sometimes because, some people feel that manipulating things is not something that they feel is right for them. They want to let nature take its course. Sometimes it's a long journey. It's basically an IVF type process, and that's a real roller coaster with all this stimulation things. So we offer the counselling, and they meet the pre-implant, the assisted conception team, who talk to you in detail about the long journey in the process. And it's not always successful either. Sometimes, you because it's a reimplanted pregnancy, it doesn't always work out. So there are many reasons why it may not necessarily work. There are plenty of people for whom it does, but it's not always something that is a successful process. And it's a roller coaster of a journey, like anybody who's been through the IVF will testify to. It is a real roller coaster, and some people feel that that's not a roller coaster they want to take on.
And is it something that everybody who has a genetic diagnosis, do they have a right to it, or is it rationed?
It's a very good question, and I think if you look overall at IVF on the NHS, there are criteria, and there are things like age criteria. There's a little bit of a postcode lottery. If you're having an IVF procedure or process because of a genetic diagnosis, the criteria are slightly different. And so, they'll take into account like things like how many children you may have had before, or your partner may have had before, what your age are, what your other medical conditions are. So it's something that your local team will need to guide you through as to what your eligibility might be. And unfortunately, the way things are with the NHS, who knows what the funding eligibility will be for IVF type processes are. That may be something that changes as well over time. So it's something that, these are things that are out there that are options, but your individual team will guide you through what's an option for where you are.
Thank you. Thank you. Thank you.
Thank you so much once again, Dr. Emmanuel.
No problem. No problem.
Thank you.